female breast anatomy. As you know, to know what is abnormal, definitely, we need to know what is normal first. And let us go together through the breast anatomy and try to understand what is the normal structures of the breast anatomy and how it's appear on imaging, and why we should know the related, the adjacent structures, and because definitely we would like to know if there is breast cancer, how it is spread and extend to the adjacent structures, and how we could appreciate this on imaging as early as possible and help the patients and the clinicians for the diagnosis and management of the patients. Okay. So, as we mentioned before, the breast is a modified skin gland that develops from the mammary ridge in the embryo. And it lies on the anterior chest wall between below the clavicles down to 6-8 ribs. And the breast tissue might be as far as medial to the sternum, far laterally to the mid-axillary line. These are important issues. We should know it. And breast tissue is frequently found in the axilla, occasionally reaching the apex. All these, it has the clinical significance. Yes, the breast usually resting on the pectoralis and extending from the second rib down to the 6 or 7 ribs down from the lateral aspect of the sternum, okay, to the anterior axillary line. But it can extend far medial, as we mentioned here, to the midline, far medial, to the mid-axillary line, and up to the clavicles, and even down. That is why while scanning the patient on ultrasounds, okay, we should follow the breast until the breast tissue is ending, up to the clavicle, up to the midlines, you see, down to the, sometimes to the upper abdomen, okay, to the mid-axillary line, and so forth. So, and as you know, the breast is resting on the pectoralis muscles. And the pectoralis muscle fibers are running obliquely, you see? And the lateral aspect of the breast is wrapping lateral to the pectoralis muscles. What is the significance of that? Do you know the significance? What is the significance for us to understand this issue? Why we should know the relations of the breast to the pectoralis and this issue? Any volunteer? Anyone knows the clinical significance for us as a radiologist? Okay. So while we are doing mammography, so we are doing mediolateral oblique rather than true lateral. See, by doing mediolateral oblique or oblique lateral rather than true lateral, we are following the axis of the pectoralis. We ensure that this part of the breast is being included into the image. So it is important for us to know the breast, you see, here is resting into the pectoralis and the relation to the pectoralis and relation to the other muscles. And below the pectoralis here is the serratus, serratus anterior. The lower third is resting onto the serrator anterior laterally. You see lateral border is anterior axillary line, and here is latissimus dorsi. You see, and superior, as we mentioned, and inferior here. This is the inframammary ridge or inframammary line. You see, inframammary fold, I mean, usually it's about the 6/7 rib, and we mentioned medially into the sternum. So, okay. So, just to emphasize on the associated the muscles in relations to the breast again. The most important is the pectoralis muscle. 2/3 of the breast is resting onto the pectoralis, while the lower third is resting here into the serratus anterior. And this is important if the posterior breast cancer, it will be close to these muscles and can directly infiltrate these muscles. We have to know it while interpreting breast imaging, okay? And laterally here, this is the latissimus dorsi, you see, at the mid-axillary lines. And inferiorly and medially here, there is external oblique and the rectus abdominis muscles. And sometimes this is after mastectomy, they are using these muscles, the latissimus dorsi and these rectus muscles in doing a flap, okay, and autologous reconstruction of the breast. We have to know the relations. Also, we need to know what is the tail of Spence. We have axillary tail. This axillary tail sometimes extending too much deep into the axilla, as seen here in this image. Compared to the other mammogram, if you look here, the breast tissue is ending here while I have another breast tissue here. And the difference between the two, this is an ectopic breast tissue while this is the tail of Spence. And here on mammography, it's okay. We're trying to cover it as a whole. Also during doing breast ultrasound, you have to pass your transducer continuously without interruptions until the breast tissue, you see, is completed. Then go to, up to the axilla, you see, to make sure there is no interruptions between the breast apex and the axillary breast tissue. To make sure if this is the tail of Spence or this an ectopic breast tissue seen into the axilla. And as the ectopic breast tissue we said before, like the regular breast, any changes occur in the regular breast is being occur in the tail of Spence or in this ectopic breast. Regarding the hormonal stimulations, it can be enlarged during pregnancy, can be get palpable, fibrocystic, can be tender, and also cancer can arise in this part of the breast tissue. It's okay. The breast is a modified cutaneous exocrine gland, as we mentioned before. It composed of skin, subcutaneous tissue, breast parenchyma, and breast stroma. These illustrations of gross anatomy of a female breast. Here the breast is resting into the pectoralis major, underneath to which is pectoralis minor, resting over the chest wall with intercostal muscles and ribs. And here, this is the skin, you see, and the central portion is nipple areolar complex with the ducts passing from the nipple back into the glandular breast of parenchyma embedded into the fat, and these are vessels. Okay. There are two main subsections we want to emphasize on. First is a breast composition and background textures. And the second is a technical issue. Regarding the background textures, we would like to know what is the appearance, okay, of these components of the breast into the imaging. The glandular tissue we mentioned before, but just to repeat again, are radiopaque on mammography, hypoechoic on ultrasound, intermediate to low on MRI. More or less, you see, iso to the muscles on MRI. While both are while fibrous septum, fibrous tissue is radio opaque, you see, on mammography, echogenic on ultrasound, and intermediate also on MRI. These are fibroglandular tissue. And this is the echogenic lines are fibrous tissue. These are fibrous tissue on ultrasounds, okay, representing as echogenic lines. So are white both here and here, and while the fat is radiolucent on mammography, hypoechoic on ultrasound, while on MRI is a hyper intense. See, so it is dark on both, and fibrous is bright on both. Okay, regarding the technical issue, our aim is to visualize the entire breast tissue as we mentioned before, to image the chest, back to the chest wall posterior, up to the clavicles, lateral to the mid-axillary line, medial to the sternum, and the most, the most important or the most helpful modality of the breast giving good anatomical coverage is breast MRI. As you have seen here, the breast MRI demonstrates the posterior lesions with not only the involvement of the pectoralis, but also extending into the intercostal muscles. It can also show, you see, the adjacent structure like lung pleura and the liver, as well as sometimes rest of the bones. On axial view, we can see sometimes even the spines and the covering of the axilla. Okay, here, this is the mammogram, you see? These are illustrations of the breast anatomy. Look here, the same structure seen on mammography. This is the nipples, and this is the echogenic. This is the bright or the radio opaque lines is the fibrous septum, and the glands, you see, is opaque, and the intervening fat is lucent, the subcutaneous, as well as fat lobule in between the parenchyma and the retromammary fat, and this is the pectoralis muscles. Okay. Regarding ultrasound, also the whole structures of the breast down to the chest wall is supposed to be visualized while doing breast ultrasound. Here from the skin, see the skin, and these Cooper ligaments extending from the skin down through the glandular parenchyma, and this is the mammary zones and the glands, okay? And here, this is superficial, anterior layer superficial and posterior superficial fascia, retromammary zones, as well as the pectoralis muscles, and here these are the ribs. MRI also, as we mentioned, it gives a good coverage from the nipples. This is the mammary glands, you see here, and the of the internal mammary vessels and the skins in the 3D maximum intensity projection post contrast, and this is what is going on. Okay, and here this is the non-fat SAT T1 image, okay, demonstrates the nipple and the glandular parenchyma, as well as the surrounding fat in the pre-mammary zone, post-retromammary or retroglandular zones here, and the skins and fat lobule within the glands. Okay, so we mentioned while describing the anatomy zone, pre-mammary zone and mammary zones, and so representing the glands okay? And the parenchyma, we have pre-mammary zones and we have post or retromammary zones. Here, this is the zonal anatomy. You see, the pre-mammary zones just anterior to the glands, between the glands and the skin, and it represents the anterior subcutaneous fat. This is the pre-mammary zones, and this is the mammary zone, you see, representing the gland, and here posterior to which is a retromammary zone, also representing just posterior to which is the pectoralis. These are the vessels, the skins. You see the Cooper ligaments, the nipples, and the ductus fat lobule in between the parenchyma. While in a fatty breast, you see, it's difficult to differentiate between the zones because the pre and retromammary zones are fat. When the glandular zones or the mammary zones also fatty, the 3 layers, it will be a fatty. However, here we could appreciate the inframammary fold as one of the important structures, a Cooper ligament, and this is a superiolar nipple. These are vessels and the skin. This is the pectoralis, and here is the lymph nodes. Okay, the mammary zones on ultrasounds, this is the subcutaneous fat. This is the pre-mammary zones, and as we mentioned, the gland is more echogenic. The fibroglandular tissue is echogenic, representing the mammary zones, and posterior to which there is a thin layer of also hypoechoic fatty layers, which is the retromammary layers. It's separable from the underlying pectoralis muscles. But sometimes it's difficult to appreciate all these zones when the parenchyma is thick and occupying the whole breast with paucity of the fat. Here, the subcutaneous fat is minimal, as well as the retromammary fat is also very thin. The breast is almost abutting the pectoralis with very thin layers here, and these are the ribs. Okay. On MRI, as we mentioned before, this is the pre-mammary zones. You see, anterior to the gland, between the skin and the gland. This is the gland, is the mammary zones, and posteriorly is retromammary zones. And here, this is the fat representing subcutaneous fat representing the pre-mammary zones, and the fat posterior to the gland retromammary zones, and this is the glandular tissue represent the mammary zones. Also, we can appreciate here the pectoralis major and minor muscles, as well as the deep fascia of pectoralis muscles. And here, this is the superficial layer of the superficial fascia covering the breast, abutting the skin, sparing the nipple area. Okay. So, as we mentioned before, the breast is developed within or investing within the 2 layers of the superficial fascia. See, the gland, the mammary gland, is seen between the superficial layer and the deep layer of the superficial fascia. This, the envelope or encapsulating the breast, except for the nipple area, the layer is extending anteriorly, you see, enveloping the breast, and completed here in continuation with the posterior layer, which, you see, separated from the deep fascia covering the pectoralis by the retromammary zone. See, this is the retromammary zone separating it from the deep fascia. It is seen on ultrasound as echogenic layer, and here as if it is giving a capsule in this digital mammography. You see, it is following the parenchyma here, this also bright layer, because it is a connective tissue, It is a fibrous, so it will appear on a mammogram as radio opaque, on ultrasound as echogenic, and also here, if you see, it's continuous except for the nipple area. Okay, pre-mammary zones, as we mentioned, is just a loose connective tissue and predominantly fat containing the anterior layer of the superficial fascia, from which arising the Cooper ligaments extending back. See, and as well as the posterior retromammary, both of which are fatty components. See, although fat, as we mentioned, although the fat in the body, in the whole body is bright, is echogenic, in the fat is appear as low compared with the echogenic stroma, echogenic fibrous fibroglandular tissue. Okay, this is the most anterior, the subcutaneous fat or the pre-mammary zones. And usually the lesions seen in these areas are dermal, are subcutaneous lesions. However, sometimes breast lesions and can be visualized here. But from my experience, I noticed that most of the lesions seen in this area, I could appreciate the superficial layer of superficial fascia coming anterior to each, as if is anterior replace breast lesions extending into the subcutaneous. However, sometimes we might find it more anterior in rare cases due to migrations of the breast tissue through the Cooper ligament into these areas. Regarding the breast, the mammary zones, as we mentioned, this is representing the glands. Here, this is a superficial layer of the superficial fascia, and this is the deep layer of the superficial fascia. Both are echogenic, are enveloped the mammary zones. Anterior to which is the pre-mammary zones, and posterior to which is the retromammary zones, which is also seen here, you see. And this is the bright area, is the corpus mammary or the mammary zones. Again, there are variations in the mammary zone depend on the breast involutions and the component of the breast tissue. If it is thicker, the glandular, fibroglandular tissue is thick, you see, so it will be a large zone, a large mammary zone. And if it is involuted breast, it will be smaller zones. And this is a mammary zone here on MRI, see? And it is, as we mentioned, it varies remarkably. And usually the distribution even within the breast itself, it varies. If you notice here, the breast involuted here, this is lateral aspect. Still, there is residual parenchyma. Again here, upper outer quadrant, usually, as we mentioned before, it composes more fibroglandular parenchyma. That is why, and the least or latest area to be involuted, that is why it has the highest incidence of breast cancer. And these changes, definitely, it depends on the patient age, hormonal status, inherited parenchymal pattern, and many factors can affect this issue. The mammary zones is a zone of breast pathology. Most of the breast pathology is seen within the mammary zones. However, the retromammary zones, you see, we mentioned before, it is an area or a thin layer, okay, of loose connective tissue and adipose tissue. That is why appear as radiolucent on mammography, okay, and hypoechoic on ultrasound. It's considered as a forbidden areas for breast cancers. We have to consider that area and to search for breast cancer as seen in this case. Here, this is our case. You see there is a lesion posteriorly here, And when magnifying view, it having a suspicious mammographic appearance. Also, this is our case. Look for small breast cancer here. It is easy to be missed due to the adjacent fat. It is hypoechoic and the fat is hypoechoic. There is no parenchyma, so it is easy missing breast cancer in this area. And this is called Chasian's fossa. The area, the retromammary area, the other name for retromammary area is Chasian's fossa, as we mentioned, is a forbidden area. Okay. Considering the gross anatomy of the breast, as we talked before, the breast is usually a complex structure, and component is also complex. It contains, as we mentioned, glandular, connective tissue, blood vessels, nerves, but we are trying to simplify these and divide it into 3 parts to talk about each part separately, considering parenchyma, stroma, and the skin. Starting by the skin. Okay, the normal skin of the breast is thin. It should not be more than 2 millimeters. It ranges from 0.5 to 2 millimeters in all imaging, in ultrasound, MRI, or mammography. You see, but it's relatively thick on at the base of the breast, and it is in younger patients. You see, and here this is the skin on ultrasound. This is the skin on MRI. Look for the dependent portion is a little bit thicker, but is still within normal, and demonstrate homogeneous, smooth enhancement, which is considered to be a normal. And the skin of the breast, like other skins, it has 2 layers or 3 layers. The main 2 layers is epidermal layers, which is very thin, superficial. It appears as echogenic lines on here, and it is separating by, separated from the dermis by a thin basement membrane. This is separated. This is the dermal layer, and this is the basement membrane. And the dermal layer, you see, below the dermal layer is the hypodermis, which is the subcutaneous tissue. So, okay. Here regarding this is the dermal lesions, you see, seen on mammography here, and an ultrasound is circumscribed, see, with the claw signs. This is typical of a dermal inclusion cyst. However, as we mentioned, even cancer can extend, you see, and infiltrating the skin, but there is absence of the claw signs in this infiltrating cancer, which is very clear. We could see the lesions extending from the mammary zones into the subcutaneous, into the skin. Focal thickening definitely is pathological. Focal area of calcifications, you see, this is dystrophic calcifications, is a pathological, usually seen with the scarring in mammoplasty breast associations, and most of the time is benign due to fat necrosis. But if we look here, definitely the skin here is normal thin skin, but in the other sides the skin is thickened, which is considered to be pathological, definitely not a normal skin. And in these examples here, this is normal skin, contralateral breast, definitely the skin is thickened. This is not a normal skin. Normal skin, thickened skin. This is even not well visualized, the skin. The other one is enhancing and thickened, definitely is an abnormal skin. And in this case here, compared to the contralateral breast, the skin on mammography is thickened around the areolar and medial aspect. And this is the ultrasound for the same patient compared to the left breast to the right breast. Look how the skin here is thickened and losing even the normal anatomic morphology. And even here, not only thickened, but even we could not appreciate the echogenic dermal and hypodermal from dermal and epidermal and hypodermal from the subcutaneous fat. I mean epidermal and dermal echogenic line from the hypodermal subcutaneous fat. There is lack of tissue differentiations and associated with underlying subcutaneous lymphatic dilatations and increased vascularity. Definitely this is pathology and not a normal anatomy. We have to consider variations. See, there is something called cavities of Coppens. These cavities of Coppens representing the hypodermal radiolucency extending into the dermal skin. You see, as seen here, these small hypo or radiolucent on mammography, and this in the magnifying view. If we have seen it, this is not an abnormal, this is a normal variance representing cavities of Coppens. It is about 2 to 3 millimeter radiolucency. And this is here on a mammography specimen, and this on MRI. This is a normal skin enhancement, and there are a small area non-enhancing low signal area here, same representing these normal variants. Also, we have to consider artifacts, especially with using of synthetic mammography. And now, just to reduce the effect of exposing the patient twice, doing 2D digital mammography and doing doing 3D mammogram or tomosynthesis. They are doing a tomosynthesis or the 3D. From the 3D, they're reconstructing to a 2D mammography and calling a synthetic mammogram just to minimize the exposure of the patient. And with these synthetic, there are many artifacts as seen here. Look for the skin, how it is thickened, and this is Allahumma salli wa sallim barak astaghfirullah. This is also thickening here. You see, in the sensitized mammography, and in these patients here, down there is thickening, and the upper portion is even imperceptible. All these are called this is called as burnout artifacts. Okay, we finish the skin, going to the nipple areolar complex. Nipple areolar complex and perinipple structures, which are areolar gland and the nipple, and it's really complex. It is a complex structures. It contains erectile muscles, which cause smooth muscles, which is involuntary muscles, resulting in erections of the nipple or stimulations. So we have to remember leiomyomas in the differential diagnosis of nipple lesions. And the nipple and areola are pigmented, you see, and the dots here are passing in a radial pattern into the nipples. The lactiferous dots in a spoked wheel, and the orientations of these ductal system toward the nipples, it has a significance for us as a radiologist in the lesion orientations. If we look here far away from the nipple area, this is a parallel lesion because it is long axis is parallel to the skin. While this, we consider it as a non-parallel or vertically oriented, because its long axis is vertical or obliquely oriented toward the skin. But when we came to the nipple area, due to orientation of the ducts, obliquely oriented lesions, we are considered as a parallel. We are not considered as a non-parallel lesions. Okay. Still considering the normal anatomy of the nipples. We described before the development of the nipple and how the proliferations of the mesenchyme below the nipples causing the nipple to develop and to get everted. But sometimes might fail to evert, or slit-like depression can occur on it as a congenital or normal variations or developmental changes, as also seen here. And because of the component of smooth muscle and fibrous component, results in heavily shadowing on ultrasound. You see, we need to put more gels and to have a different technique to avoid this and to visualize what is going below the nipples. And also the nipples component is abundant of lymphatic tissue, which they call it sabis plexus. And this also has a significance in lesions being close to the nipple, you see, or the nipple involvement by breast cancer is readily metastatized to the lymph nodes. And here, this is the MRI, this is the nipples, and this is the base of the nipple, and the shaft of the nipple is called a papilla. You see? Also consider the assessment of nipple areolar complex. Its assessment is really important, as we mentioned before, is important for the staging, especially in the risk breast cancer screening. And you know that its involvement is very important in therapeutic planning, and especially for those who even if they want to do a mastectomy, the nipple sparing mastectomy, it will not be the options of treatment if the nipple is being involved by breast cancer. And that is why we have to understand the normal anatomy and normal morphology, normal enhancement on MRI, so as to differentiate what is normal from what is abnormal. We mentioned the nipples contains devoid fat, contain muscles and connective tissue, that is to include in the differential diagnosis. And also we have to know that the ducts are passing, you see, the lactiferous ducts are passing into the nipple, and even the epithelium of the ducts is in continuations with the epithelial of the skin of the nipples. And the significance of that is Paget disease. You know the Pagets, see, arising in these ducts and extending into the skin of the nipple. And okay, type. The nipple, it should be homogeneous. There is a lesion here within the nipple. It could be related to these ducts, or could be related to the muscles or the connective tissue structures within the nipples. Also for the ducts, and as we mentioned, the ducts, it should not be more than 2 millimeters and should be hypoechoic. There is nothing should be seen within the ducts. Looking at the nipple itself, there is no added density, should be, as is seen here, as if there is a microcalcification seen, but by repeating the image, you see, and clearing this area, it was an artifact rather than a calcification, while in this case, it is a true calcification and nipple is a little bit enlarged, this reflecting a pathological conditions. The nipple should be bilaterally symmetrical, should be seen on profile on and mammogram. If it is not seen in one view, in the other view, it should be seen in profile, and as we mentioned, to be symmetrical. When it is slit-like depressions, we said this is a retracted nipples, you see, but being bilateral symmetrical, this is most likely will be, and there is nothing seen behind, this most likely it will be a developmental. On ultrasound, nipple is really challenging, challenging. If you start by this, it looks like a mass-like. It looks like a pseudomass. It looks like not hypoechoic with shadowing and this. But when we compare with the mammogram, look how it was perfect. Factual is not a real one. Here, and this is 2 examples. You see the nipple look like a pseudo mass, as well as in these lesions. While here we could appreciate the nipple itself, so it is a little bit flattened at the level of the skin. You see, not inverted, but it's flattened, but there is a true lesion definitely seen within the nipples. And in these examples, the nipple is retracted here. You see, asymmetrically retracted, and there is abundant signal echoes, vascular echoes seen within, and definitely this is a pathological nipples. The nipple, as we mentioned, there are variations, and it can be everted, it can be flattened, it can be inverted. These inverted nipples on MRI simulating or mimicking and enhancing mass. It can be malpositioned. In this mammogram here, the nipple malpositions giving apparent small lesions. When repeating the mammogram here, this is a marker, it's seen the nipple in profile. Another MRI here, this is spurious findings due to malpositions of the nipple itself, like on mammography, showing the nipple within the breast tissue as a pseudo mass. The nipple morphology, mostly in 75%, it's been everted. However, it can be flattened and occasionally can be inverted. So inversions, congenital inversions with benign findings, usually reducible. If we are doing the ultrasound, you might find it is being re-everted in positions. You see, while physiological, usually fixed, and usually is asymmetrical. And congenital nipple, usually bilateral, but in some percent, like 13%, can be a unilateral, and inverted nipple sometimes, as we mentioned here, can mimic a lesion or a mass. Okay, on MRI, these are bilateral, everted, normal enhancing nipples. See, symmetrical is really important. Symmetrical enhancement is important. When we see normal, symmetrical size, symmetrical enhancement, everted nipples, mostly these are a benign findings or a normal findings. And the enhancement, this enhancing superficial enhancement is a normal MRI findings, and rarely can be extending into the areolar area, but when we see this, it is usually seen in both sides. And there is zone here of non-enhancement. We call it non-enhancement zone. It has to be present if there is internal enhancement. You see, to say this is a normal enhancement, we need to see these zones, and the enhancement can be patchy. The internal enhancement can be patchy or can be linear, see? But definitely, this is asymmetrical enhancement. It's involving the base, it is continuous, is enlarging the nipples, see? Compare the two sides, asymmetric size, asymmetric enhancement, not following the routine, the usual pattern of normal enhancement. In a case of 32-year-old lady with presented with history of family history of breast cancer, and that was the presentations for her malignancy, okay, picked by MRI. And this is also another patient of breast cancer. You see extending ductal carcinoma in situ, extending down into the nipple here. This is definitely, the continuation is obvious, and this is abnormal nipple enhancement, and this is not a candidate for nipple sparing mastectomy. Okay, considering the nipple areolar complex, the Montgomery gland is part of an important issue we have to mention. From my experience, is really common usual problem in coming to radiology department. Even almost every day or every other day or 2 or 3 per weeks, we receive patients complain of her nipple area, and only we found that this is related to Montgomery gland. I don't know about the literature, they did not mention this is very common, and I don't know if it is related to certain area more than the others area, but from my experience, it is a common presentations, see? And these Montgomery glands are sebaceous, are a modified sebaceous gland, considered as intermediate stage between mammary or milk gland and sweat gland, because it contains a small amount of milk. So this is not the exact function of which its function is containing a lubricant materials that contain even antibacterial agents. And these glands are getting enlarged during lactation and pregnancy to lubricate the nipples for and facilitate the functions of suckling for the baby, and protect the mother nipple from cracking and from get infected. However, these glands by itself, you see, sometimes its ducts get blocked. It can be blocked, you see, and get inflamed. They open into the skin surface by what is called Morgagni or Montgomery tubercles. These elevations, okay, into the skin, or these bumps are the Montgomery elevations, and usually are not getting large or getting presence, you see, until pregnancy. It will become obvious, and there are variations between female and the others. Some they have a lot, some they have little of these, and they usually range from 4 to 25 on each side of the breast. And as we mentioned, become noticeable during lactation. If you compare here are larger compared between these two female. And if you see here, there is bright discharge from this due to milk. Tiny milk can be discharging from this Montgomery gland, and even if it gets infected, can result in periareolar abscess, as in our case seen here. Okay, we finished the skin and nipple areolar complex, going to breast parenchyma. And the parenchyma, it represents, as we mentioned, represent the glands. It forms mainly of the lactiferous ducts, okay? Here, these are the lactiferous ducts going back into segmental, subsegmental ducts, ending into acini or alveoli, forming the lobules. Okay. There are each breast having about 15 to 20 lobes or sections. So we have about 15 to 20 lactiferous ducts going toward the nipples. And these larger ducts, okay, dividing into segmental, subsegmentals, and going back, okay, to terminate in the terminal ductal lobular unit or the acini. So we have many sections. Here we have many sections, and the sections, these are lobes. The lobes containing hundreds and hundreds lobules, okay? And the lobules contains multiple acini and alveoli, which are the factory of the milk. And these sections are embedded into the breast stroma and separated by the Cooper ligament or the fibrous septum. The ducts, the lactiferous ducts going toward the nipples is getting large here, forming the lactiferous sinus. And rarely this lactiferous sinus can be more superficial and rarely can be palpable. She might, the lady, she might palpate this lactiferous sinus, but this is not a usual presentations. And it should not be more than 3 millimeter, and the ducts, it should not be more than 2 millimeter. And it should be echo-free, containing fluid, not containing any echogenic materials or hypoechoic materials. These are examples of the ducts. This is a ducts, okay, lactiferous ducts, and its branching arborizations, but it's all within the normal caliber. This is a normal ductogram. This is also normal ductogram, but this tiny nodule due to a lobular plush, normal plush due to pushing the contrast, more contrast, or with pressure. The contrast pushed with pressure. But this MRI here representing a dilated ducts, you see, and this also mammogram with multiple dilated ducts due to ductectasia. Again, this is mammogram with a dilated ducts. Same patient on ultrasound, demonstrate multiple dilated but echo-free. So this is just a ductectasia, simple ductectasia, while the ducts here containing internal echoes. So definitely this is this is a complicated type of ductectasia, not a simple ductectasia. This even size-wise is abnormal, and abnormal, more complicated by internal echogenic materials and the presence of increased vascularity even in the periductal area, considered an abnormality or pathological in this case of a periductal mastitis. And in the other patients here, this is a duct is dilated, considered abnormal on mammogram, and the corresponding ultrasound demonstrate intraductal material with intraductal vascular echo, signify this is to be a soft tissue in a case of papilloma. So the only normal is this ductogram, while the remaining are considered abnormal. So we have to know the normal to differentiate what is abnormal. Gross anatomy of the female as stromal component of the breast contain two parts, which is fibrous stroma and fatty stroma. The fibrous stroma is the connective tissue, you see, connective tissue and the ligaments. As we mentioned before, this provides support for the breast, and the suspensory or the Cooper ligament extend from the skin and holding the breast to the posteriorly to the pectoralis, giving support for the gland. And if these being infiltrated by the by breast cancers or by malignancy, it get triggered, it gets shortened, result in puckering of the skins, which can give the typical appearance of peel of orange or BD orange. You see, as seen here, this is a BD orange, you see, and this is thickened, diffusely thickened Cooper ligaments. These are the Cooper ligaments or connective tissue are thickened due to breast edema on mammography as well as on this MRI. Look how it is thickened, okay? While these on ultrasound, these Cooper ligaments are normal, smooth ligaments, echogenic fibers, not showing any abnormality. Also can be focal, not always, not necessarily to see throughout the breast. This is malignant lesions, and these are the Cooper ligaments due to perilesion, infiltration, lymphatic infiltrations, and edema are get thickened. You see, extending up to here, while far away, still the breast is not getting edematous and the Cooper ligaments are not involved. And even the effect on the adjacent skin is visualized. Regarding the fatty stroma, the breast, as we mentioned before, the breast is a bag of fat. The major component of the breast is fat, and the gland is being embedded into this fat. And as we mentioned before, the fat is black or radiolucent on mammography and echolucent on or hypoechoic on ultrasound. But when there is a pathology, the fat might get increase in density due to edema and perilesion edema, as in this case. And here, compare the fat lobule here on this normal ultrasound, and these fat lobule are getting large as well as become so echogenic. And even here, there is lack of differentiation, tissue differentiation between fat, gland, and skin due to diffuse breast edema, and everything is getting echogenic. And here, this is a neoplastic process causing this diffuse breast edema. Okay, the Cooper ligaments, as we mentioned, it should be thin and well-oriented, not distorted, not thickened, not increasing size. This is normal Cooper ligament. These are the Cooper ligament in illustrations. These are Cooper ligaments here on mammography. These are Cooper ligaments, normal. But if we look here, these are Cooper ligament a little bit thickened and associated with calcifications. So definitely we consider this is a pathology. And here there is distortion. The Cooper ligaments here is distorted, and the adjacent contour of the fat glandular interface is also distorted. And this is early mammogram, and this is follow-up mammogram. Now is getting increasing in size, and on MRI demonstrate abnormal enhancement in a case of malignancy. This and look. Following the follow-up mammogram is usually important to recognize any subtle findings regarding the breast anatomy, gross breast anatomy, or radiographic anatomy. If you look here, this is the concavity of the fat glandular interface. In the follow-up, there is a slight bulge here, and in 1 year follow-up, and another follow-up, look for the bulge. So it is subtle, this bulge is subtle, and even the adjacent Cooper ligament are getting thicker in a case of evolving breast cancer. And this is a spot magnification view, is not disappear, it persistently present, and this is ultrasound demonstrate a lesion in a case of evolving breast cancers. Okay, breast, like other structures, having blood vessels and lymphatics, as well as nerve system and so on. And the nerve supply of the breast is usually from the intercostal nerve. And just to remind that the secretory function is not controlled by this nerve supply, and it's controlled by the hypothalamic pituitary gonadal hormones rather than the nerve supply. Regarding the vascular supply, the two major vessels of the breast are the internal branches of the internal mammary and the lateral thoracic from the axillary artery. But there are others branches supplying the breast, the thoracoacromial of the axillary, the lateral mammary branch, and the mammary branch of the intercostal arteries. See, all these are supplying the breast. And this is the MRI, here demonstrate the internal mammary branches going medially, as well as this is the lateral thoracic artery. In this image, obviously, the vessels are asymmetrically enlarged and increase, okay? Increase in size and increase the branching due to the presence of this malignant mass compared to the contralateral. And on MRI, not only the vessels, if you look here, even the vessels are asymmetrically larger compared to the other side, and there is intense parenchymal enhancement compared to the contralateral, also reflecting increased vascularity in this size compared to the other size, also in a case of a breast carcinoma. Regarding the venous drainage, we have two systems of venous drainage of the breast, the deep and the superficial. Sorry, this should be the deep venous system and the superficial. Regarding the deep venous system is following the arterial anatomy. See, same as the arteries, the deep veins are following and draining into the parallel veins, while the superficial, which represent more of the main system or the major system, and is impaired, is not following the arterial, and usually we have seen a superficial vein just beneath the skin on ultrasound. And this is usually a challenging, especially in a case of thrombophlebitis. You see, in the case of thrombophlebitis, sometimes the lady presenting with a tubular, tender swelling, mostly on the outer upper breast, you see. And when you put your probe, you might find the tubular interrupted structures. You see, you don't know if this is, you might get conflict if it is ducts or veins. And here usually the Doppler might help you and might show some flow in part of the veins, because if it gets thrombosed, you might not see flow throughout the veins. Also important venous structures is, we have to mention it here, is the posterior intercostal veins, which join what's called Paston venous plexus. And the Paston venous plexus is a network of valveless veins in the human body that connect the deep pelvic venous veins and the thoracic veins. It is usually drain the inferior end of the urinary bladder, the breast, and the prostate to the internal vertebral venous plexus. So the posterior intercostal veins join the azygous, hemiazygous system alongside the vertebral. See, alongside the vertebra here, okay, connecting to past on vertebral plexus, which go to the internal venous plexus surrounding the spinal cord. Because of their locations, and lack of valves, so they believe that it is a way of spread of cancer to the vertebral column and to the nervous system, as well as to the skulls and the pelvic bones. So the pastern plexus is part of the cerebrospinal venous plexus. It's also considered the same way as metastatic spread can be considered as spread of the infection and osteomyelitis of the back from the pelvic infections and so forth. These vessels seen on mammography, lateral thoracic, it is normal size. Here, more dense due to calcifications. And this one is hugely dilated, even seen here on ultrasound. So we can put color Doppler to visualize why it is hugely dilated. There is a lot of differential diagnosis for these dilatations if it is either local process, okay, dilated due to underlying pathology in the breast and the blood supply is increasing and new vascularity, or due to vascular anomaly itself, but most of the time is related to the more central venous obstructions. Like superior vena cava obstruction can also result in enlargement of the breast vein as part of the chest wall venous collaterals and this issue, and also due to engorgement, central engorgement or chest pathology. Sometimes we might find the breast is becoming edematous, and it will result in a challenging, if it is this edema is related to venous problem or lymphatic problem, central or systemic, whatever, or due to an inflammatory carcinoma, especially because we could not appreciate or we could not find definite mass or pathology within the breast. And this case here is a thrombophlebitis, you see, with a dilated vein seen on mammogram as well as on ultrasound. Okay, the most important part is the lymphatic system. And it is really of great clinical importance. Why? Because the lymph node involvement is the main prognostic factor, and independent of other factors like tumor size or these, for predicting overall survival and progression-free survival. Nodal status also influence the therapeutic indications, and the tumor involvement of axillary node is an indication to neoadjuvant chemotherapy. Supraclavicular indication for radiation therapy. The absence of clinical nodal involvement and allow to consider option for sentinel node, see, procedures, and therapy avoiding unnecessarily surgical sections if the sentinel node is negative. Okay, so the main lymphatic drainage of the breast is known to be toward the axilla. And so, look here, it's going toward the axilla. In these illustrations, we have many levels here. Level 1, 2, 3. We have to understand, and we have seen here directions of the lymphatics. So here, this is the axilla. We have seen here colored This is pectoralis major, pectoralis minor. Again, on the sagittal view, pectoralis major, pectoralis minor. And this is pectoralis minor on coronal, separating level 3 from this level 1, and so on. Let us go through this one by one to understand. Before that, look here for these examples, see, of axillary invasions on PET scanning. In the first example A, this is level 1, see, external to the pectoralis minor, corresponding to TNM stage N1. This invasion of level 1, external to pectoralis, and level 2, posterior to pectoralis, corresponding to TNM stage 1 if loose node. If are clinically fixed, it will be stage N2. Okay, see, this is the pectoralis. This is lateral and this is medial. So we are talking about level 1 and level 3. So corresponding TNM N3. Ipsilateral supraclavicular, TNM N3. So it is really important to describe the nodal involvement by locations, by levels, which nodes is being involved. It will change the stage, okay, of disease process, and definitely changing the stage will reflect for the therapeutic selections. Okay, let us go for the pectoralis and the 3 levels of the nodes. There are many levels of, there are many groups of lymph nodes in the pectoralis named by what and so, but for us, okay, this is the most important to describe the 3 levels and the Rotter's node. Okay, from oncology and surgical point of view, just simplify things. These are the most important. This is the pectoralis minor. We said before the importance or the significance or relation of the muscles to the breast. Though the pectoralis minor is not directly in contact with the breast, it is behind the pectoralis major, but here it has so important clinical significance because the levels of the lymphatics is being related to the orientation or locations of the pectoralis minor. If it is lateral and inferior to which it is level 1. If it is behind the pectoralis minor, it is level 2. And if it is superior medial to which it is level 3. Here in cross-sectional anatomy, this might be CT or MRI. Look here. This is a pectoralis major and this is a pectoralis minor. Lateral to which is level 1, medial to which is level 3, posterior to which is level 2. In between the 2 pectoralis is the interpectoral or the rotor node. Okay, this is ultrasound here. This is pectoralis major and pectoralis minor. Okay, pectoralis major, pectoralis minor. So this is lateral and this is medial. We have level 1 and we have level 3. And obviously these are malignant lymph node. Here again, we have level 1. No, this is medial here. This is level 3 and this is posterior level 2. And this is supraclavicular lymph node, malignant lymph node. And this even retrosternal. So in expert hand, you see, they can visualize by ultrasound the retrosternal mammary, internal mammary, malignant node, but it is really challenging. Okay. As we mentioned, the dominant pathway of breast cancer is axillary, but there are alternate routes of lymphatic flow. Rarely, it might go to the internal mammary nodes, okay? Originate from both medial and lateral, though more commonly the medial aspect going, and the internal mammary even, see, cross the sternum to the contralateral breast. So it is one way of contralateral involvement from the through the internal mammary pathway. Also, there is a retromammary pathway, see, from the deeper portion of the breast to the subclavian plexus. These occur a little bit much more than the rest. When the usual lymphatic plexus blocked, there are other pathway can be open and can be involved by the spread of lymphatics, which include directly from the breast to the contralateral breast. And though this is rare, in my experience, I have a couple of cases I could trace the malignancy from medial aspect of one breast extending through subcutaneous, through the midline, cross midline into the contralateral breast. Also, the other way is cervical nodes and peritoneal cavity and liver through the diaphragmatic pathway or the rectus sheath. Okay. Lymphatic drainage of the breast, look here how it's so anastomosed. Almost all pathways here showing a lot of anastomosis. And it's usually arising, the lymphatic arising here from the lobules, okay? It flows through the intramammary lymph nodes and intramammary lymphatic channels toward the stapes plexus in the subareolar regions. As we mentioned, this area is rich in the lymphatics, and from these plexus going toward the axilla, either directly or through these chains of lymphatics. Lymphatics from the left breast is going to the thoracic duct and subclavian, and on the right side to the subclavian vein. What is the clinical significance of this anastomosis, a lot of anastomosis of the lymphatic pathway? What is the clinical significance for that? Any volunteer? Okay. This, we can expect a sentinel node to be located outside the axilla, which is the lymph node, which is defined as the first lymph node draining the tumor site. So it might be outside the axilla. And the development of lymphatic mapping is really essential for visualizing these drainage pattern, and as we mentioned, for prognostic and therapeutic purposes. Okay, as we mentioned, the breast going to the axilla, level 1, level 2, level 3, just to make it simple, these levels, and sometimes infraclavicular node considered part of level 3. From there, going to supraclav, you see, and here, this is the internal mammary. And as we mentioned here, these are anastomos, even this internal mammary can go through the vessels, go up into the supraclavicular regions. So we have group of lymph nodes of interest. We have to look at intramammary lymph node. In case of malignancy, sometimes we can notice that there is a malignant node or can be involved by the disease process when it is present intramammary or present on imaging. I mean, the axillary lymph node, the 3 levels, 1, 2, and 3, the rotors ligament, the rotors nodes, I mean, sorry, the supraclavicular and the internal mammary, contralateral, and diaphragmatic nodes. Okay. So we know the pathway and the nodes, the interested nodes expected to be involved by the disease. We want to know when we say these nodes is involved or not. Starting by the ultrasound, which giving a high sensitivity and specificity over the mammography and the clinical in evaluations of the lymphadenopathy. This here, an long axis and short axis of an axillary lymph node. In a short axis seen as a C shape, as seen here, and long axis it has a reniform or an oval shape with a central, see, hyper-echoic hilum, and this is the echogenic capsules and part of the cortex, and this is hypo or isoechoic cortex. And here we have to mention that when it is hypoechoic, it is isoechoic, sometimes it's difficult to be visualized within the axilla. You need to use the harmonics, okay, to help the visualizations of the lymph nodes. So by harmonic, it might get a little bit hypo and could be differentiated from the adjacent fat of the axilla. And if we look here in both, the cortex is uniform and thin. It is less than 3 millimeter, considered to be normal. 3 millimeter and above, we have to consider it as pathological. Okay, we have to know the anatomy, detailed anatomy of the lymph node to understand the involvement of the lymph node by the disease process. The lymph node look like the kidney. It has the kidney shape, see? It has the hilum through which the vessels is getting in and the efferent lymphatic vessels getting out. However, the afferents are multiple and getting into the cortex through the capsules. And just beneath the capsules, we have the cortex. And the cortex are two parts. We have superficial, this is part of the cortex, and we have another, a deep part of the cortex, and then the medullary portions. Okay. So it depends how much the cancer cells getting involved, the nibble getting involved, the lymph node, coming to the lymph node through one single afferent or multiple afferent vessels. In this case here, is getting through one afferent vessels into the subcapsular sinusoids, going into the insides in the cortical sinusoids. Here within the cortex, these are the lymphoid follicles, okay, and getting deep into the deep cortex. Then going deep, then till to reach the whole lymph nodes or the hilum and central portions of the lymph nodes. So the morphology is more important in evaluation of lymphatic lymph, of axillary lymph nodes or the metastatic lymph node rather than the only the size. Size is not a predictor factors. And also by using the Dopplers, we will see how it can help us. Look here, this is lymph nodes, not much big, but there is irregular cortical thickening. You see, in expense compressing the hilum in a case of malignancy, and this is how it is irregular cortex, you see, and here definitely this is peripheral cortical vascularity, new vascularity signify this is metastatic or pathologic metastatic or malignant lymph node rather than just reactive lymph nodes, though this lymph node demonstrate homogeneous or uniform cortical thickness, and still there is a peripheral fatty hilum, but look for the vascularity. This new vascularity signifies this is a malignant lymph nodes. This is not a normal lymph nodes. And here, look for the late morphology. This is the same lymph node. Follow up. It was in the short axis and long axis. Then is getting in the long axis, getting more circular, and then losing its normal shape, normal textures, no even residual fatty hilum, and even losing the capsules and infiltrating into the adjacent structures. So this is definitely malignant lymph node. This is our patient's bilateral reactive lymph nodes. Look, yes, there is cortical thickening, however, is uniform cortical thickening, which still could appreciate some fatty hilum. And when you see the vascularity, so it is abundant vessels with much more arborizations, however, is going through the hilum, then arborize into inside the lymph node, reaching the cortex, not coming from the reverse, from the cortex, and coming. Look for this one, so that it is symmetrical cortical thickening. However, look for the cortical peripheral vascularity, and even here, this is the vascularity. These are definitely abnormal vascularity in a case of malignant lymph nodes. Okay, again, this small lymph node with here might be suspicious for a small bulge in the cortex, but by putting the color Doppler, definitely this is a higher vascularity, but this is peripheral cortical vascularity signify it is metastatic lymph nodes. Okay, these lymph nodes here, the cortex and the medulla, and there is another area, faint hypoechoic. What do you think? Is it this hypoechoic? Is it signify infiltrations, malignant infiltrations? Definitely no. Why definitely no? Because the cortex is intact, and it is always metastatic involvement is coming to the lymph node through the cortex. So that is why we need to know the normal anatomy, okay, and these and the relevant related abnormality and pathway and this involvement and this issue to understand, to differentiate normal from abnormal, and even to differentiate between different types of pathology itself. In this case, this is a medullary portions away from the cortex. The cortex is normal, definitely is not a malignant process, and the lymph node is enlarged, and this is usually seen in the elderly patients due to repeated inflammations and fat infiltrations, benign fatty infiltrations of this area result in this issue. Compare with this small lymph node, but here the pathology is related to the cortex. This is uniform, but the adjacent lymph nodes, this I might say it might be reactive, but since the adjacent node is suspicious, so this is also a suspicious lymph node. Mammogram is not very sensitive for evaluation of lymph nodes, okay? Its sensitivity and specificity much less than ultrasound, but in advanced node, definitely it will be the suspicious effect, it will be visualized, as in this case, this is a malignancy, and definitely this is level 1 malignant lymph node, and also these are dense, very dense lymph node with lack of fatty hilum compared to the contralateral lymph node, and compared to this bilateral normal with thin cortex and abundant lucent fatty hilum. However, in this our case, if we look here, look for the mammogram, there is large area of fatty hilum, okay, seen here, as if this is large lymph node and this a fatty hilum. But compared to the ultrasound, here, these are multiple adjacent lymph nodes with irregular cortical thickness and even indistinct borders. And that was the only abnormal findings, see, could be appreciated in this young lady having metastatic disease. Look, compare with this in the literature. This is reported as a normal, typical normal lymph node, same as this lymph node, but that was proven, pathologically proven metastatic lymph node. This is the same patient here. See, before looking for these same patients, the CT is also helping us in evaluations of the lymph nodes and giving overview for almost all levels, axillary levels, and even characterization of the lymph node itself. Look for this lymph node is almost same size or even larger than the index breast tumors. Our patients, we have seen her mom just now, you see, look for these lymph nodes. Those are not much larger, but if we compare to the contralateral, definitely these are heterogeneously enhanced, lacking the fatty hilum, and there is perinodal edema. See, and we report these are as suspicious lymph nodes, and the patient, in this patient having metastatic bone disease, and we raise the suspicions for the breast carcinoma. Looking deep into the breast, we could appreciate only this small lesion, and it was the source for extensive metastatic disease and this axillary malignant node, and all were proven pathologically. MRI is even more sensitive and specific than ultrasound in evaluations the malignant axillary lymph nodes, differentiating from benign, even with early low level of suspicions. Definitely this here, it's obviously metastatic or malignant type of lymph node, distorted, rounded, or global with lacking of fatty hilum and intense enhancement. However, in this case, with left breast cancer, at this level, see, bilateral comparable with abundant fatty hilum and thin cortex. It doesn't show as any level of suspicions. But going down, this is post-contrasty when, while these are T2, definitely these are asymmetric compared to the other sides with some cortical thickness, and this was suspicious and proven to be neoplastic or metastatic lymph nodes. Okay. This pectoralis minor, pectoralis majors, you see, and the chest wall. So we are dealing with which level? We are dealing with which level of lymph node? And this is the same patients here. Huh?
Level 2.
Which level? No volunteer?
Level 2.
It's posterior to the pectoralis, so it will be level
2.
No answer?
Level 2.
Okay. It will be level 2. We said lateral to the pectoralis is level 1. Pectoralis minor. Posterior to the pectoralis minor is level 2. And medial to the pectoralis minor is level 3. Okay. So here, this is the pectoral group, vessels, and this is the lymph node on ultrasound. This medial aspect, here is lateral. And this the lymph node, this is the vessels. Here, this is the pectoralis minor. So this is not the lymph node. This is not lymph node. The lymph node are here. So it is, this is the thickest part of the pectoralis. So, and this is the shoulder. So this, it will be level. These are external, are lateral. So this, it will be level 1. Okay, this is level 1. And what about this one? Which level?
Level 2.
Anyone would like to answer? Any volunteer?
Level 2. This is posterior.
If we look for the structures, what are these? What are these structures? This post-contrast study T1. These are the ribs. And this is the intercostals muscles. So this is, it will be, this is the breast, and this it will be internal mammary vessels. Yes. So this lymph node definitely will be
level 3.
The internal mammary node. See? And the other one, this one is axillary lymph node. Okay. So in large lymph nodes, and they mentioned that metastasis to internal mammary lymph node. In the presence of axillary, they consider it N3, or and it will change the stage to stage 3C. Okay. What about this case? This, the lymph node here, very large lymph node, and look for the lesion itself, very small lesions. What is your explanation for this? Or why very small lesions giving this huge axillary lymph nodes? The metastasis is larger than the lesion itself. So it's early metastasized. Why it is early metastasized? Look for the location of the lesions. It is in the retroareolar region. It's close to the nipple areolar complex, where the abundant lymphatic system, and so early metastasis. Okay. What about these patients? This extensive malignant process within the breast, the CT, this is level 1, and this is level 3, and this is hepatic metastasis. So it is almost stage 4. This is metastatic disease. Okay, so we finish the gross anatomy, and we said the glands, this is the glands, you see, and the adjacent stroma, fibroglandular, representing the mammographic hyper or radio opaque structures, and lucent area, the intervening fats. Okay, and we mentioned that the breast composed of about 15 to 25 lobes or functional unit, more or less separated by fibrous septa or the Cooper ligaments, and within each lobes we have many lobules, hundreds and hundreds lobules, and the lobules contain small units. Okay, these small units, we call it alveoli or the acini. See, the smallest unit is acini, and representing the functional part or the factory of the milk. And these, the ducts, are arranged into spokes wheel going toward the nipple. Okay, And if you look here, the ducts, central ducts, are going direct to the chest wall, while the others are going into the radial patterns. And previously they mentioned that these segmental ducts, segmental and subsegmental ducts, are interdigitating, and they believe, before they believe that are interconnecting, but current studies dispute this anastomotic effect, and they mention that are only interdigitating due to lack of true anatomical separation. Yes, there is septation, there is fibrous septum, there is Cooper ligament passing between the lobes and even between the lobules, but it is not a true anatomical boundaries between these segments. And the segmental ductal structures are passing from one segment to the other segments. So, okay, going more toward the microscopic structures of the breast, we talk about the ducts, the lactiferous ducts. We said that the lactiferous ducts, then it get branched into segmental and subsegmental, and these subsegmental going into smaller ductules, and these ductules forming these ductules representing the alveoli, and collectively the cluster of these forming what is called a lobule. And as we mentioned early in the development of the breast, we said rudimentary breast start intrauterine by developing only ductal system, but at pubertal period, due to hormonal stimulations, these ductal branchings getting complex, developing more complex organogenesis or more complex ductal formations, and then formations of these terminal duct lobular unit. So what is terminal duct lobular unit? It is area of lobules or cluster of alveoli, and within these alveoli there is intralobular terminal ducts. See, intraductal terminal, and these are drained into extraductal terminal ducts. The extraductal terminal ducts, the proximal one, along with this lobule together, forming what is called terminal duct lobular unit, which is influenced by hormone, as we mentioned, and these the important site for breast proliferations and benign as well as malignant breast diseases. And as we mentioned before, this is the factory of milk productions. See, this is the factory of the milk productions. And if you note here, you notice that this lobule is surrounding by this color representing a special type or a specialized type of connective tissue stroma containing capillaries. All this, it has significance regarding the breast pathology. And since this development of influence of the hormones and developments of more lobular duct, terminal duct lobular units occur during pregnancy, the theory describes that there are stem cells at these terminal ducts responsible for the formations of these terminal duct lobular unit, and since occur repeatedly during pregnancy, it might stay up to 60%, and they consider these might be a precursor for a breast cancer development also. Okay, during pregnancy, look for the terminal duct lobular unit and the surrounding stroma of a normal lady, non-lactating lady, and see it here during lactation, how it's getting proliferating and enlarge both the stroma as well as the epithelial portions. Okay, so going more microscopically into these structures. This is a duct, and these are lobules. You see the ducts, and this is a lobule. If we are taking this here, this is the acini, this is the acinus, the ducts, the lumen, and this is the acinus. So there are two layers of epithelial cells. The inner layer, call it the luminal cells, which is the secretory cells secreting the milk, and the outer layer is the myoepithelial cells, which is the basal, considered to be the basal myoepithelial cells, which is the smooth muscles responsible for the ejections of the milk, okay? And the outer layer is the basement membrane, which is not interrupted, and this determines the differentiation between the in situ carcinoma, you see, which does not passing outside the base membrane, to the invasive cancer, which infiltrating into the basement membrane. And the presence of these multiple types of cell system cells, ductal and lobular cells also form of luminal cells as well, myoepithelial cells, reflecting the cancer heterogeneity in terms of cell origin. Okay, the terminal duct lobular unit, we said, is the commonest place for the formations of, for the benign as well as breast cancers. And breast carcinoma, DCIS, lobular fibroadenomas, and phylloides, breast cyst, epicrine metaplasia, adenoses, fibrocystic, all these are occur at the terminal duct lobular units. And here, this at the level of terminal duct lobular unit, look for this is a normal, while this here is a cyst. And these examples of different types of pathology, while the papilloma usually arising in the main ducts, you see, and ductal hyperplasia also is a ductal lesions here, but the fibrocystic and fibroadenoma, sclerosing, and DC are at the level of the terminal duct lobular units. These examples, ductogram, you see, demonstrate the dilated ducts, but the peripheral terminal duct lobular units doesn't show any abnormality on this ductogram. This is again a dilated duct with internal lesions, demonstrate vascularity in a case of intraductal papilloma. Going further, the ductogram here demonstrates these small contrast, rounded or oval areas of contrast flush into the terminal duct lobular unit, but are small, are tiny, are not enlarged, just due to flush of contrast due to pressure. It represents normal terminal duct lobular unit, while this terminal duct lobular unit in the other examples, look how it is dilated in a case of a fibrocystic disease. And here, this is a normal, but are numerous, are a lot of terminal duct lobular units. That is why looking as if it is dense mammogram, but it is a ductogram, and there are numerous terminal duct lobular unit, more glandular breast, but these still within 2 millimeter or less in diameter, representing a normal terminal duct lobular unit. While these illustrations or this photograph of a histology image demonstrate here, this is a normal terminal duct lobular unit, while this definitely enlarged terminal duct lobular unit, and these acini within the terminal duct lobular unit also enlarged in a patient with fibrocystic. Okay. What is your observation just regarding the gross anatomy of the breast in this case? Just we are trying to apply the gross anatomy on breast imaging. What is your observations, huh? Volunteer, Suhair is not there? You don't like to participate today? Don't like to contribute? Hello? No one is there? Okay. So,
Yeah.
this is obviously here, we have asymmetry. The right breast is significantly smaller
not in
compared
profile.
to the left breast. If we concentrate, even there is subtle change in the contour here, and there is some thickening in the periareolar skin. There is some distortion in the contour, and there is thickening of the areolar skin. So might reflect pathological process. Going further, this is dense breast. Going further, so the pathology at this level is asymmetry in the breast size. Going further to MRI, so obviously here the asymmetry. The right breast is smaller compared to the left one and demonstrate intense, non-extensive, non-regional or non-mass-like enhancement. And biopsy revealed invasive lobular carcinoma, and compare the mammogram with the earlier one, this asymmetry, it was not there. So not always cancer result in enlargement of the breast, can also result in contractions of the breast, and which make it getting smaller. And this asymmetry, but there is nothing associated with this asymmetry. The left one is significantly smaller compared to the right. However, the parenchyma and the fat and the skin and everything doesn't show any abnormality. So since there is no abnormality associated with this, asymmetry is virtually always will be developmental. And usually, as you know, during puberty, early on, in early stages, there will be asymmetry, but when we reach stage 4 and 5, then the asymmetry disappear, and both breasts more or less getting to be more near symmetrical. However, if any persisting asymmetry, then it might be getting increase this asymmetry if the lady gaining weight, and more fat accumulating can give more, the asymmetry appear more disproportionate between the two breasts. Okay, what about this?
This is skin lesions.
No one is there?
These are skin lesions.
No comment?
Could be also multiple cysts, fibrocystic disease.
No one would like to share?
Fibrocystic disease, multiple cysts.
Hello? Aywa?
Doctor, people are answering,
Okay.
but you are not listening.
If
They
we
are
look
answering.
here, if we
They are
look
answering,
here,
but you are not listening.
these are bilateral numerous obesities. But looking carefully, some of these lesions are related to the skin. So are superficials, are skin lesions. These, because it is 2D, are the skin lesion are projecting over the breast, and even here projecting over the axilla. In a case of multiple skin lesions reflecting what?
Neurofibromatosis.
Neurofibromatosis. Okay. But the challenge is here. Within these multiple lesions, there is an speculated lesion here, which represents a carcinoma. So in neurofibromatosis 1, there is increased risk of breast cancer by factor of 5 over the general populations. Okay, this is a neurofibromatosis with breast cancer. In conclusion, we talk about the breast anatomy, gross anatomy, resting over the pectoralis, relation to the adjacent structures and muscles, and the breasts covered, invested within the superficial layer of superficial fascia covered by the skin. We talk about the nipple areolar complex, the ducts going back, forming the glands or lobules. You see, these are the ducts here, and these are the lobules, and the lobules contain also ducts, okay? And the gland is embedded into the stroma and fats, and we talk about conveys into extralobular terminal ducts, then going toward the lactiferous ducts, and multiple lactiferous ducts reflecting the underlying breast segments, which about 15 to 20 are conveyed to the nipple area, and we differentiate some of the normal and abnormal breast changes. And at the end, we can say, as with all organs, understanding of anatomy of the breast lead to an enhanced ability to interpret imaging studies. And the breast imaging primarily involves the assessment of morphology of macroscopically visible breast structures. However, basic understanding of the anatomy and histology of the breast and the complex underlying microscopic structures in which changes take place is an important for understanding the pathological process, and all will help in image interpretations. And generally, the radiologists are pattern readers. We are all pattern readers. However, rather than just searching for a pattern, interpretations should be tried to understand, or interpreter should be tried to understand the underlying process that produce these morphological changes and give these various imaging studies. And the different process might produce similar findings, but getting deep into morphology and histology and pathological changes by understanding the anatomy of the breast and organization and distribution of these histological elements, it will shape the imaging findings. Ideally, the interpreter should be able to explain using specific criteria why a finding is judged a benign or a potentially malignant by being able to explain the specific characterization of the findings can lead to particular assessment. And also, this understanding of the anatomy will help us in cross-correlation the internal breast anatomy for localizing breast lesions in different imaging modality. Thank you very much.